So morning, everyone. So of course we just started, and we will wait a couple of minutes so so people can join. So we're here today to talk about primary pain condition for this webinar, for this Q&A, and we are joined by two of our presenters now. So we will start with a short introduction by each one of them, and then we will kick off the question. For the question, you can ask them directly in the chat box below, or you have the Q&A function. So thank you all for being there. And I see that you are joining quite fast, so that is great. So maybe Anton, you can start by presenting yourself.
Yeah. Okay, thank you, Lauriane. I'm Anton de Laat. I'm a dentist from training, but afterwards I've been focusing a lot on orofacial pain and dysfunction. I've always been based at the University of Leuven, the Catholic University of Leuven in Belgium. And since last year, I'm retired, so I'm working from home and only visit the clinic one day a week or something like that.
Super. How about you, Rainer?
So hello, everybody. My name is Rainer Feinhagen. I'm head of large pain department in Germany, in Munich. I'm seeing pain patients every day. I'm an anesthesiologist since, must have been now 30 years, but pain is my research topic, and I must admit neuropathic pain is my love. So we're doing a lot about that, and since 10 years, we're eagerly working on the question, what is mixed pain? We had a couple of very interesting, I think, discussions and publications about that, and that's when we made up this idea about a talk of what is mixed pain between nociceptive, neuropathic, nociplastic. I think you might have seen that. Oh, well, now I'm here and I'm waiting for your eager questions. So welcome, everybody.
So super. Just for your information, attendees, Indre might join us a bit later. So we will start with a question with our two speakers there. Just one thing that I wanted to, that I noticed when watching all your presentation, there were kind of a link in all your presentation. There were, a link to the nervous system with the central local injury affiliated to the pain syndrome. There were also a broad range of symptoms with a broad range of potential cause. And for all three of you, there were low evidence of efficacy of treatment, with either a need of more research or better strategy for pain management, which might be a bit overwhelming, I guess, for some people. And Indre just is joining, so that's great. So just I wanted, then one of my first questions would be to ask you either any updates on pain management and any recommendation. But first, we welcome Indre. Do you hear us?
Hello. Yes.
Yes. So we already introduced our two other speakers. So could you just give us a quick introduction of yourself and your topic?
Yes, my name is Indre Junger, and I am working as pain clinician and physical rehabilitation doctor at the multidisciplinary pain clinic in Stockholm. The clinic is called St. Göran's Hospital. We're situated in the middle of the city. So we are working with different kind of pain patients, including post-COVID condition patients with pain problems.
Super. And so I already introduced the other one. And as I was saying, I've seen a link of, between your three presentations where you have a strong link with the, nervous system with a broad range of symptoms, broad range of potential causes, but also low evidence of efficacy of treatments with either a need of better strategy or more research. And so my first question will be to you, Indre, because I know you have to leave a bit earlier today. Is there any new evidence or recommendation for management of pain in post-COVID condition?
Yeah, it's a very good question. It's because the presentation was recorded last year and we did not have so much evidence. And during the last year, we have a lot of studies published on pain problems in patients with post-COVID-19 condition, which is called now. We have at least the same name for the condition, not many names that we had before. It's called post-COVID-19 condition, according to World Health Organization. And World Health Organization has released recommendations for COVID-19 rehabilitation. It includes also post-COVID-19 condition. So there are some recommendations written there regarding pain condition, but mostly only joint pain. So we, of course, would like to have more recommendation from World Health Organization regarding myalgia and neuropathic pain, like pain syndromes in these patients, but we hope it will come with time. And I'm very, very glad to see many reports coming about pain, description of different pain features in these patients, risk factors, and I mean, EFIC on the website, EFIC's website, there is a task force for COVID-19 condition. So please look at the papers, at the webinars which are recorded. We have information provided, and we hope that more evidence will come soon.
Fantastic. And so now we are waiting a bit to have to receive questions from attendees. Don't hesitate to write. I had a question for you, Rainer, because your topic was a bit more broad on mixed pain, and you talk about the importance of implementing a third mechanistic descriptor, nociplastic, and by IASP. Why was it so important to add a new category to the description of mixed pain?
Well, of mixed pain, I think because the three mechanistic descriptors we have nowadays, which is nociceptive, neuropathic, and now nociplastic, is not enough. Clinically, we do see in most of the patients who are showing up in a clinic or in a pain praxis an overlap of all these three types of pain. And the terminus mixed pain has been used within the last 3 decades, manifold in lots of publications, but it was always used in different ways. So if you do not have a straightforward definition of what mixed pain means, it's definitely not easy to do straightforward research. And everybody has another concept of what mixed pain really means, and another understanding. And that's why we started a couple of years ago meetings all around the world to bring together, let's say, a starting point for an international recognized definition. While this in parallel was done by our international group, the ISP came around the corner with a third mechanistic descriptor called nociplastic pain. And this is just a semantic term which was suggested by the ISP to describe this third category, which was formerly described simply as a dysfunctional type of pain. But everybody was always asking, what is dysfunctional? What does it mean? How can we categorize these patients? So the mechanisms that underlie this type of pain, mixed pain as well as nociplastic pain, they are not entirely understood. But I think it's necessary to do a bit more research about what is meant if we're using these terms. And this is why we started it in 2019 and why I gave this talk last year.
And I had just a follow-up question about that regarding, because I guess it might be a bit difficult to have a patient coming and having to explain to them that they are feeling pain and we have that there are no lesion, there are no physical evidences of their pain. How do you deal with that when you have a patient like that? How do you explain to them that it's a different kind of pain that they are feeling?
Well, you asked me how I deal with this terminus nociplastic.
Yes.
Well, we see that very often because this type of pain can occur in isolation, but it often occurs in conditions such as fibromyalgia, tension type headaches, and these are all part of, let's say, a mixed pain state where you see a combination of, let's say, different types of pain, ongoing nociceptive or neuropathic, and in an overlap. It might occur in chronic low back pain, but I think it's important to recognize this type of pain, since each and any type of specific pain will respond to different therapies. So if a patient asks me about his type of pain, I'm not going into deep and I'm discussing with him about pathophysiology. But what I always try to take into account is, for me, the idea, what is behind this type of pain I'm just looking at, and how do I have to choose my therapeutic approach? I think this is the most important thing. If people are asking me about the nociplastic state, this is really not easy because you cannot show anything. If you look in a functional MRI, you see the whole brain is full of red spots and everything is working there together and against. But I tried to make them understand that this is a problem of an augmented central nervous system, and that this is the sensory processing, which is altered pain modulation. I don't tell them it like this, but I try to make it in very easy words. But this is exactly what we nowadays understand what, for instance, fibromyalgia is. It's an altered pain modulation in the CNS, which is leading to pain, although we do not have any kind of let's say, lesions we can show.
And what I usually add to that is that, especially because of the chronicity, that you have a gradual, let's say, expanding of the potential mechanisms underlying the pain. It might be that at the start you are more dealing with the nociceptive pain or something which is recognized by the patient, but the longer the pain remains, you also can see changes within the wiring system itself. And then, of course, you get these combinations that we can then discuss, mixed pain or nociplastic pain or whatever. I mean, it's a combination, but in that particular circumstance, it's the chronicity, especially also, who makes that we have this kind of overlap and diffusion of the potential mechanisms.
That's an important point, Anton. It's a kind of wind up over time. Exactly.
Yeah. And I wanted to add up also a little bit on what you previously said with regard to definition. I think if you go back to burning mouth, which was my topic last year, one of the major problems over there was also that there was not a clear definition and certainly not clear criteria, which also hampers, of course, good research in the future. And in this regard, last year, we have made big progress in this, that finally the international classification for orofacial pain has been established. And finally, this was a cooperation between different groups of clinicians, not only dentists, but also the neurologists, also the headache people have been working together on that, which now probably will offer us the opportunity to have at least a good definition, also strict criteria, which will allow to do better research in the future.
Yeah, I would like to add that mixed pain and burning mouth syndrome and headaches and fibromyalgia and nociplastic pain are very often found in patients with post-COVID-19 condition. So I think we are a very good symposium here at this webinar, because I mean, you can see all kinds of pains in post-COVID-19 condition.
Mm-hmm.
And Inge, how does it happen when you have someone with long COVID syndrome, which might be a mixed pain or burn mouth syndrome? Do you take care of them yourself, well, or your department, or do you then send them to a specialist in this condition and still working with them to help with the patient? Either like my question would be more like, do you have multidisciplinary, work on each patient, or do you have to actually send them to a specialist afterward and still following them specifically for the long COVID syndrome?
Yeah, thank you. These patients which come here, they're well investigated, so they have been at cardiologist, met cardiologist, they met maybe lung clinician, they made different investigations. So it's important that it's also underlined in the this report, World Health Organization report, that the patient should be investigated, and there are suggestions what kind of investigation should be done. But in very many situations, there are no findings which have to be treated by other medication. Maybe maybe some tachycardia or maybe some asthma-like medicines are prescribed, but it's only some diminishing of the symptoms of cardiovascular and breathing symptoms, because these patients also have dyspnea very often. So when we get patients here, they usually have already been at different doctors, at least having a primary healthcare doctor who is monitoring other symptoms or other like conditions in the post-COVID-19 condition. And pain is another one which is remaining, and it may be quite disabling if pain is very exaggerated. I have cranialgia patients with different kind of headaches, and it's even for me difficult to classify it with headaches. I usually like saying cranialgia, or burning mouth syndrome, or fibromyalgia like pain. So, and we usually working with pain, but we had conducted a study where we also were working on breathing therapy, including mindfulness therapy, of course, it is a multidisciplinary approach, because we see that, for example, pains in the chest, they are related to breathing. When patients starts to breathe, they get pain in the breast chest, and it creates anxiety and creates fear, and we have to learn them to start breathing again. There are different exercises as well as we know that for nociplastic pain treatment, it's important to have a physical therapy, but it's not unusual that these patients, they have POTS-like symptom. It means postural orthostatic tachycardia syndrome. So they have to train in lying position. There are special exercises, so they have to do exercises, but maybe for them it's difficult to do exercises by standing. So we have to train in the lying position. So we have to adapt the rehabilitation approach to these patients, even from the pain rehabilitation, which means physiotherapy, which means sleep ergonomy. We have different approaches for these patients. So in your question, yes, we have to be investigated, but we also have to adapt, including more. We have to be open to monitor and to manage even more symptoms, not only pain by itself, because everything is connected: breathing, cardiovascular system, sleeping in this condition.
Okay, thank you very much. Yes, Rainer?
May I just add something to this? Because you ask, do you refer them back to somebody else? I think the strengths of pain medicine and a multidisciplinary pain medicine is that we can offer answers, and that we can offer answers by a couple of different entities. We have psychologists, we have orthopedics, we have pain physicians, we have neurologists, and we're all working together. The problem for those who are showing up with post-COVID type of pain is that they're completely lost in translation, at least in our country, because they're running from physician to physician to physician. They don't get any answer, but they don't get any treatment. And this is the problem. I see a lot of patients with polyneuropathies post-COVID. I see a lot of patients with headache post-COVID. And what I think the strengths of pain medicine is in a multidisciplinary setting is that we can offer at least treatment, that we can say, okay, now you're here, and now we try to figure out what is going on and what we can offer. Even if we do not have so many answers yet, but we have to offer something to the patients.
Okay, brilliant. Thank you very much. And I think we received a couple of questions for you, Indre. So one would be, for post-COVID-19, you talked about a possible autoimmune pathway. Are the mechanisms known? And right after, there were a similar question. You talked about multidisciplinary approach, and could an anti-inflammatory diet play a role in it?
Yeah, I think there are studies going on on these directions, autoimmunity. And I am I have been working with the myalgic encephalomyelitis, it's chronic fatigue syndrome, which is similar to post-COVID because both are post-viral fatigue syndromes which contain many symptoms. So in somehow I am glad, I should not be glad, that so many researchers, so many foundations now are engaged to find the answers. So before it was very difficult to apply and get money to make research on chronic fatigue syndrome, but now it's available, and we have very strong research groups working on autoimmunity, for example, on postural orthostatic tachycardia syndrome, which also may be some immune approach there, and also on diets. There are interesting studies on raw food diet, for example, showing that maybe some kind of gel mechanism are starting, which are feasible or good for the post-COVID condition from the autoimmune point of view. So I don't have a right answer. I just want to say I am happy that so many studies are going on, and these studies, I think, will bring answers not only to post-COVID-19 condition, but as well to all these nociplastic pain conditions or fatigue-related conditions. When we have complicated pain conditions, we have many symptoms, and I think they're connected with each other through immune system, through nervous system, and I expect, I'm waiting for studies coming that I know there are a lot of granting in Sweden for example, to study autoimmunity. So I don't have right answer, but I hope it will come, and we have to be open to find answers to these disabling conditions.
Thank you very much. And I would like to pursue with related, maybe not to diet, but Anton, in your presentation, you discuss about people relieving their pain with mint or ginger.
Yeah,
For
but this is,
syndrome.
Well, some of the research being performed, which has been performed in the burning mouth syndrome, has elucidated the role of receptors. One is the TRPV1, which is in fact, one is quite well known, and the other one is TRPM8, which in fact is responding to mint. So the capsaicin that is already a long-standing trial is working especially on the TRPV receptor, while mint especially works on this TRPM8 receptor. And what my experience is personally, that is that for patients who can try this out and have more the inclination to try this first before they start, let's say, the medication, because it seems simpler. It seems like a local, very, let's say, topical treatment. I have the impression that it is or. It is not both. Or you see a result with capsaicin rinses and they say, okay, I feel much better when I do that a few times a day. Others say, no, the capsaicin is certainly not giving me improvement, but on the contrary, but if I use mint, I have a lot of progress. So, I mean, I think it's or. We cannot do them both at the same time. And this is certainly in the approach that we have up to now, the first step that we try to see whether we can bring down the intensity or the frequency of the burning using very topical means. And ginger can be one, mint can be one, capsaicin can be one. So this is also something which can at least give some kind of improvement. And depending on the remaining pain, then it's of course also possible to add medication.
Interesting. And actually, we receive a question for Raina. Do we know anything about risk factors of mixed pain?
Well, that's a pretty good question. Unfortunately, I have to say no. Nevertheless, we know that specific diseases are linked in a very high number to mixed pain states. What we definitely know is that individuals reporting mixed pain, and that was what I showed in my talk, that they show higher pain intensity, higher degree of disability. They have, it seems so, a higher level of depression and anxiety. They have a lower physical and mental quality of life, lower sleep quality. All these comorbidities seems to be more important for those. And what we also know is that We have many patients with neuropathic pain linked to spinal pain problems, linked to cancer pain, linked to post-operative pain. Low back pain as such seems to be a very high risk to run with mixed pain. But there is not enough research yet that we can say these are really clear-cut risk factors to develop a specific type of pain or mixed pain. I think it's much more linked to the pain entity, osteoarthritis, cancer, low back. These are those who show much more this overlap of different pain types.
Okay, interesting. Anton has also another question for you. So you indicated that it was mostly prevalent in peri and postmenopausal women. So of course with a strong, with an endocrine components. And I was wondering if the burning mouth syndrome was also found into younger women with similar endocrinal deregulation, and if it was also found in male, but what would be the cause for males?
Yeah, it's a very good question. I think from my personal experience, first of all, the younger females who are confronted with the burning mouth syndromes many times had a history which also, let's say, interfered with their normal hormonal household. I would say if you have young females who have been undergoing hysterectomia, for instance, or who have something like a disease behind them that has changed this ratio between the 77 hormones, then this was in fact the possibility. I'm going to shut this down. Okay. For the males, I have in my own career, I think maybe I've only seen like 10 males in regard to hundreds of females. So it's very, very tricky to say that it might be, let's say, an equal distribution. I think especially males are rare with this syndrome. And certainly now, if you take a look at the potential, let's say, confusion that has existed up to recently, because then we had to make a distinction between the primary burning mouth syndrome, which we discuss right now, but also the secondary burning, which might be resulting from a lot of other factors. I think certainly in males, you should first take a look on whether this is one of the potential causes. So to be clear, I think it's a major group of these peri and postmenopausal women. For the younger females that I saw, there was usually something which has been going on with their hormonal balance, whether it be as a result of a surgery, whether it would have been as a result of medication or some kind of therapy which interfered with this ratio.
Okay, very interesting. Thank you very much. And we receive another question for you, Indra. How valuable are QST for the diagnosis of the adequate treatment of the post-COVID-19 pain syndrome?
What do you mean, QST? Or,
yes, QST. Sir.
QST. QST we're using mostly to detect thresholds. So we can use QST by determining for determination of thresholds of cold threshold, for cold, for warm, for touch, maybe not for cold and warm, yes, yeah, for touch. But I don't think we can diagnose. I mean, we should use pain analysis. I always tell to my students, pain analysis is the key to understand the pain and maybe even pathophysiology and the treatment approaches, what kind of pain, and to have knowledge about how nervous system is functioning, both in periphery and the central nervous system. So QST is only looking for pain thresholds or for thresholds in the periphery. So it's we can use that to understand if there are changes, if we suspect neuropathic mononeuropathies, for example, or polyneuropathies. But even in fibromyalgia, we can in some of patients, we have very decreased thresholds for different modalities. So it's not the key diagnostic measure. We have to look at the criteria. We have fibromyalgia criteria, For example, if we're thinking about generalized pain, we have to use pain paintings to ask pain intensities, pain duration, these classical questions when we're talking with patient about his or her pain. So I suggest just go to the basic. And post-COVID-19 condition, it's more what you say specific, that we have the same virus. It's more specific. I mean, in chronic fatigue syndrome, we have different viruses which creates condition, but here we have almost the same virus theoretically. So it should be more homogeneous grow, but it's not at all. It's very heterogeneous when we look at the phenotype of symptomatology, but we have maybe the same factor causing that. So unfortunately, I have to go back. I would like to promote a conference on post-COVID-19 condition, which will take place in Stockholm, but it's also available online. And I hope it also will be announced by EFIC in EFIC calendar, or maybe on COVID-19 task force. There we will gather specialists working in rehabilitation for post-COVID-19 syndrome condition. We're not going so much on diagnostic, but what is new, what are the recommendations from World Health Organization, how people are working abroad, and how people are working in Sweden with rehabilitation issues, and pain issues also will be included, as well as rehabilitation for cognitive disability, and both for having mild infection before and being hospitalized. So I just want to say to those who wants to hear more about post-COVID-19 condition and rehabilitation update. Okay, thank you very much. I have unfortunately to leave, and good luck to everyone by studying our webinars.
Thank you, Indra.
Bye, Indra.
Bye.
If I may just add to this question of QST and post-COVID, because I'm working with post-COVID patients a lot, because they show up here more and more. As long as we do not have a real understanding what is the underlying pathophysiology of post-COVID, and I think there are different ones. The inflammasome and headache is discussed now. There was a nice publication which you could have found in Pain just 2 years ago. So we have different understandings of pathophysiology, but we are not there yet. So with this, QST is not really the first line diagnostic approach. Nevertheless, we see a lot of patients showing up after post-COVID with at least, it looks like small fiber neuropathy or polyneuropathy as such, even a large fiber polyneuropathy. And for that, we definitely use QST to show that there is a damage within the nerves, and that we can really prove that there is a damage. QST is extremely helpful for this.
Okay, interesting. And actually, to continue with mixed pain and kind of linking with the bone marrow syndrome, where we saw prevalence in perimenopausal women, is there any specific part of the population which is touched by mixed pain, or it's everybody can be affected?
No, everybody is open to get it, and that's the problem. So just to make clear, mixed pain is not an infectious disease where you can say maybe more women or maybe more men. I think mixed pain is just a semantic terminus which is important to use in the same way. We should all use the same definition and not everybody something else. And that's why we started this discussion about what is mixed pain and how can you understand mixed pain. I think for me, it's clear that it is an overlap of these different pain types we have now discussed and described by the ISP, these three: nociplastic, neuropathic, and nociceptive. And this overlap, this is mixed pain. But why is it so important? Because if you try to find out the right treatment approach, mixed pain needs more than only an opioid or only an NSAID, because we have this overlap. And if you just treat one specific type of pain, like let's say neuropathic pain, you might left out the nociceptive one. And this will never be a successful treatment for our patients. And that's why the discussion about mixed pain is so important. If mixed pain is a pathophysiology with its own right, like nociceptive or nociplastic or neuropathic, I highly doubt, I don't know that. But what we see is we have overlap, and we see that in 90% of our patients. And therefore, just keep it in mind that in most of the cases, you should really consider about mixed pain and how to treat patients you look at.
And regarding that, I feel like it might be a bit different between, okay, you have mixed pain and you have burning mouth syndrome. For mixed pain, you indicated that currently the treatment guideline is based on the pain phenotype, which mixed pain would be insufficient. So what would you recommend instead? While in burning mouth syndrome, I feel like people really focus on also the pain phenotype. And do you have also other, you Anton, recommendation for a different way, different strategy to manage pain?
I think, at least for the group of patients that I see and that are confronted with burning mouth syndrome, I try to explain to them, first of all, that we do not have a clear, let's say, symptom that can be traced within their tissues or within the tongue, and that it has to do with something like a change in the sensation, and that has to do something with the wiring itself. And then, of course, you are already discussing the fact that you talk about neuroplastic or neuropathic-like pain, which then has developed into a neuroplastic pain as a result of chronicity, like I said. The moment that you have also other potential causes which might be more nociceptive, then I can imagine that you're going to work also on two tracks, like also Rainer has said. You should then, of course, tackle not only the local problem. I can imagine that you have some kind of irritating situation in the mouth with some kind of teeth which are not smooth enough or things like that. But that can, in general, be handled quite easily. The difficult part is the one which has to do with the fact that they have some kind of another thresholds to signal this kind of burning, and that has to do, of course, with the nervous system. You can try then to damp the input, which then probably has been done by masking these receptors, like we discussed with capsaicin or mint, or you can try to bring down the filter, or let's say to work on the general sensitivity threshold of the nervous system, which is at this moment in overdrive. And then, of course, you go into more antineuropathic medication. But sometimes you do both. Right? If you have a potential distinction or a potential bifocal cause, then of course you can also do a double treatment, so to say. One is then focused more on the nociceptive part, and the other one is more focused on the neuroplastic part. Okay. I don't know whether this is an answer to your question, otherwise it may be a misunderstanding.
No, it was perfectly fine. No, I was really wondering about the strategy, because these burning mouth and mixed pain are quite difficult to wrap your head around if you don't have any background in science or in medicine. So it's difficult when you say to someone, well, you have a physical pain, but it's actually not. But it might not be really a local issue, but more a central issue.
Yeah. And
so I guess you said it with a really nice wording. So I'm sure patients are happy to have you as your doctor. And
I must admit, if I can add that, if you take yourself time and if you really try to explain your patient what is going on, and you do not need to use these specific medical words, they should really understand what is going on. That you say that there is something in the brain which is due to a wrong modulation or whatever, they appreciate it because they start understanding what is going on, and they stop looking for, let's say, a local problem, for a disease which might be in the tongue or might be in the muscles for fibro, and they start understanding that this is the most important thing. Take yourself time, because without time, you will never make it. And this is not a 5-minute talk. This is really something which takes half an hour or even longer for patients to understand.
I completely agree. I think that the moment that you can explain to them that the nervous system as such is running on its toes and
Exactly.
has much less input necessary to, let's say, trigger off this kind of problems and pains, then they understand. They understand. Yeah.
And I think it's even more important for them to understand and to be able to explain that to their family and medical workers, because we've seen a lot of people dealing with psychological issue where they are sometimes are misunderstood, like, oh, you don't look like you have anything wrong with you, but you feel pain. And
Yep.
at least with this kind of conversation, they are
Yep.
able to not
That's a
justify themselves.
very important point. I must say, over the last years, this has been improving, but I've lived it through the times that patients with burning mouth came to me and said, even my GP, my physician, says that I'm crazy because he doesn't see anything and he never heard about this. So there has been a time in which that these people were really desperate because no one understood what they had. And at this moment, I say this is much better right now, probably also because of the divulgation of all this knowledge. Gradually, people get to learn and in the moment that you can publish something in a more general, let's say, a magazine or whatever, then things go into a change. But it has been very, very difficult for many of these patients, for sure. And of course, it's like this, that if you have been faced with such burning mouth syndrome for quite some time, because this takes for years, it's quite logic that you also will have tendency to be depressed. It's of course that you have anxiety because you're fearing that you have some kind of a cancer that someone did not see. And that is the reason that, of course, you have to really interact with these patients in a very structured, but also time-consuming way to try to explain to them that things are not, let's say, wrong from that point of view, but that is something that has to be tackled on with a management of a, let's say, a nervous system which is not functioning properly anymore.
Yeah, I would say these patients with pain problems, which are still not yet well understood, 50% of them have, all of them, I would say not 50%, all of them have at least once heard that this is all in the head, This is psychiatric. You need to go to a psychologist, to a psychiatrist, because this is nothing we can understand, and this is all in your head. And this is the problem. But if you really take yourself time and try to convince patients that it is in the head, in the central nervous system, and I always try to make it easy to say it's like driving a car. You use a gas pedal and you have a brake. The brake might not function very good anymore, and it's the same in your brain where this brake is not working. So people start understanding. And I think this is the most important thing, to tell them we completely understand and we take it really for given that you are in pain and it's not just a psychiatric problem.
So do you both feel like GPs should be a bit more educated on this type of syndrome, and that if they don't see something per se on the scan, they might refer to a different kind of a pain specialist, maybe?
I certainly do not want to blame the GPs. Huh? I think it's very
You need more
important that you
education.
try to inform them, and the fact that in the past they were not able to respond properly has also been taken as blame for us, that we did not do the teaching properly enough.
So I think it's not only the GP. You're completely right, Anton. We see a lot of specialists who do the same. It's just a question of time, a matter of time. GPs are so bright and they do so many good things, and I see so many brilliant GPs as well as specialists, but there are always some people who have no idea of anything, and those are the ones who usually say this is all in your head and you should go to a psychiatrist. But so many GPs, they refer patients to us with a right diagnosis of, let's say, even nociplastic pain written on the referral. So you see, there's nobody to blame, but bringing knowledge to our colleagues is always important, always, because they're treating hypertension, they're treating a prostate problem, they're treating diabetes, and there's no time left over to treat, let's say, specific pain. So with this, I think don't blame anyone, but bringing knowledge, and the EFIC is doing that. I think this is the most important step in the right direction.
Fantastic. And even actually a communication to the public and patients, I guess, would be even more important, that they might come to their GP saying, well, I have this pain and, I'm not sure if it's something physical or if it's something a bit more neurological. And like, so that would help, I guess, the GPs orient their patients towards one specialty or another, or with a specific, a response for them at least.
Yeah, this is needed. We offer once a month at least a digital patient forum, and we have up to 200 patients from all over Germany linking in and just listening to these specific topics. It can be migraine, it can be post-COVID, it can be neuropathic pain, it can be something specific, it can be back pain, everything. But people are really interested and they're seeking for answers.
Mm-hmm.
Fantastic. And so we have a last question for you, Anton. Could burning mouth syndrome be linked to some nutrient deficiencies like mineral or vitamins?
Yeah, I think certainly in the past, this was a first phase that we had to go through to rule out secondary burning. I explained to you earlier that now for the new definition, we only talk about burning mouth syndrome the moment that it is a primary condition, the moment that you have some kind of a potential reason, and some deficiencies in food might be one. Then you talk about secondary burning, but you're not talking about the burning mouth syndrome anymore. That is to be clear with regard to the definition. In the past, we did usually a workup in which we checked for a deficiency in vitamin B12, zinc. Diabetes was also taken a look at to see whether there was some kind of potential underlying reason. But with regard to normal deficiency for food, I never encountered something like that. But in the past, you could, of course, iron has to be taken into. You have some kind of deficiencies could be linked to burning. But the secondary burning at this moment mostly has also to do with a polymedication, and that is something which you have to explain to the patients too. The moment that you take more than 3 or 4 medications, it's quite normal that you have some kind of dryness and some disturbances in taste and potentially also even some burning. So this is all secondary. But for the primary condition, I did not read anything about specific deficiencies in food.
May I ask a question, Anton?
Yeah.
With this, let's say, just as an example, a patient with a burning mouth due to chemotherapy, would that be a secondary burning mouth syndrome by definition, or is this just burning as a symptom?
Yeah, I think the one that you ask right now, chemotherapy, is not an easy one. In fact, if you know the reason, then you talk about the secondary burning. The definition as such right now is that you have ruled out all these things. But I think in the past, chemotherapy was not considered as being a primary cause for burning, because chemotherapy as such can be an attack for the whole nervous system, from which then burning mouth syndrome might be one of the, let's say, regions where it is expressed. It is thanks to the research that has been done since the 80s that one makes the comparison between a small fiber neuropathy in the level of the tongue and in other parts of the body. So I can imagine if chemotherapy is the underlying reason, that it takes, of course, also a role in this burning mouth syndrome. But by definition, you would talk about the secondary one, but the approach would be the same, of course, as you do with the primary one.
Okay.
So we only have 10 minutes left. So unless these additional question, would you like to have a last word or last sentence for our attendees, or something that you would like to convey, or you would like people to, as a take-home message? Anton?
Well, not really a take-home message. I think that first of all, people should realize that we are in a better position than 5 years ago with regard to definition, with regard to potential, let's say, criteria, to be sure to talk about homogeneous groups for the research going on. Secondly, I think that with regard to the management of these patients, time is at a very important point. Explanation, so that they are not worrying or not having bad ideas about their own role in this development. And then usually we try to find out a potential way to, let's say, diminish the symptoms in frequency or intensity. I'm very, very let's say, hesitant to say that you can solve it. I think that in general, we are already very, very happy if we can bring it to a state in which it is, let's say, manageable by the patient. That is a livable situation. But to really get rid of it, and then for sure rid of it for the rest of their lives, I never talk about that because it's quite tricky. And then in the management, we usually try to first take the simple approaches that we discussed with the topicals, and then afterwards we take the potential, let's say, anti-neuropathic medication, and we try to find out whether this one of them of these can give them some relief.
It's still an hopeful message that you say that we are in a better place than in 5 years ago. So hopefully in 5 years more, we will be able to
Hopefully
go further. How about you, Rainer?
Well, no wrap up, but I would just say explicit screening or diagnostic criteria for mixed pain are at least not yet available. Nevertheless, we should never forget as physicians, it really doesn't matter what you do, orthopedic, if you're a pain physician, if you're a dentist or whatever, that a good diagnosis has to be made up, and that is based on a good clinical judgment. And this should always be done with a detailed history taking and a thorough physical examination. Never forget that. Take yourself time if you approach a patient as a pain physician, because without time, in 5 minutes, you will never make it to the right answer. But if you keep in mind that we have different, let's say, primary pain conditions and that they may show an overlap, if you take that in mind, you will definitely come out with the right diagnosis and will definitely have a good approach to, let's say, successful treatment.
It's a really strong and important message. Thank you very much, Rainer. Thank you to you, Tom. I hope that you enjoy this discussion. And I would like to thank you both again and thank the attendees for their question. It was really insightful. And we hope that we hope for you a nice afternoon.
perfect.
Thanks to all of you joining us.
Thank you very much. Thank you.
Stay safe.
Yes,
and,
until next time, who knows?
A nice weekend. Bye-bye.
Nice weekend to all of you. Bye-bye.